is July. Just to frame this, this was the month that I picked up from Dr. Dashevsky doing the pediatric TB in Lattimore. This was the second session that I had run, and she brought us a surprise. Any guesses? Not George, since he's heard me complain about this so many times. That's correct. So she came in for her scheduled visit to tell us that her last period was May 8th and that she had been to her primary medical doctor who did a pregnancy test and it was positive, and the patient believes she's about 2 months pregnant. She was there with her mom, and I will say they were very, very concerned about the possible adverse effects on the pregnancy from either tuberculosis or the medications. The patient was thrilled to be pregnant. There was never a consideration of termination, which I did ask her about. They just wanted to make sure that everything was going to be okay. But just to say the timeline, we still had another 8 months of our planned 12 months of 3-drug treatment going. So that's where we're at that moment. So what would you do now?
So, David, while we answer this, can I ask you whether she was counseled beforehand at the time of diagnosis?
So she was. And actually, I went back and even reviewed the documentation. She was counseled both on the inpatient and outpatient setting about avoiding pregnancy, but she was also denying sexual activity. And in fact, she was specifically counseled that, even if she were to start oral contraceptives, they might not be as effective because of drug-drug interactions. So there were multiple counseling sessions about this, but there wasn't anything more done. And I had discussed with Dr. Dashevsky after the fact, was there a consideration for something like an intrauterine device? But, in a teenager who's also telling you that they're not sexually active, that did seem like it would have been overkill.
Right.
In retrospect, no, it wouldn't have been, but I don't think any of us knew that at the time.
Right.
I
think in terms of just the polling question, it seems like all of these things are reasonable things to do. Of course, it would have been, nice if the parents, I'm sure I'm an adult doctor, not a pediatrician, but I'm assuming most parents don't have an idea that their kids are sexually active. Right. But if they had and perhaps they didn't say anything about it, was mom involved in the counseling sessions? Is that what you would generally do?
Yes and no. I mean, there was counseling without mom there, just to ask the questions. Mm-hmm. And then, for the majority of the counseling sessions, yes, mom is there.
Okay.
And text or chat question, she was not on B6 at that time. When I saw her, I actually started her on prenatal vitamins and sent her to our maternal fetal medicine people, but also counseled her pretty extensively that given the severity of her TB disease, we really had to continue to treat her TB disease. And we would just try to figure out what the best thing for her would be. So again, extensive disease, cavities on the CAT scan, resistance, 4+ sputum. But the question is, and the question for the rest of this revolves around the use of a fluoroquinolone in pregnancy. And if you Google fluoroquinolone in pregnancy, some bad things pop up on your screen. You know, I did try to explain to her that, you know, she's not having a puppy, and many of those adverse effects were in, you know, dog studies, but that was a source of concern. I did actually talk to Dr. Larzabal and Dr. McSherry, and we, in going back and forth, decided that there are much, well, not much, but stronger data for the use and safety of levofloxacin among the fluoroquinolones in pregnancy, which one study you'll see in a second. There are also better data for the neonatal use of levofloxacin. Not that that necessarily correlates to safety and use in pregnancy, but that we just have a better feeling of it, a higher level of experience with it. So she was switched from the moxifloxacin to levofloxacin. So she continued the meds throughout pregnancy. I did have to meet with her a couple times. There was a 2-day period where she was refusing DOT because she didn't want something bad to happen to the baby, and that correlated with a OB visit where she saw a resident that told her that these medications were unsafe in pregnancy. So I had to do a little counseling intervention there, but she generally understood and wanted a healthy, you know, successful pregnancy both for herself and for her baby. So she did continue the therapy. We monitored her very closely. Probably got more LFTs on her than we have in the entirety of the pediatric TB clinic since I've been there. She completed her treatment in February, so a full year of therapy, and delivered literally 7 days after her last dose of tuberculosis therapy. Luckily, she delivered a full-term, normal, healthy baby girl. And, you know, I didn't put in the slides, but I actually called the neonatologist and said, you know, I need you to do me a favor. Just go do an extra thorough exam on this baby and, you know, really tell me everything's okay. And everything was fine and has been fine. This is her end of treatment x-ray, just for completeness sake. So if anybody has any questions about the case, we certainly can talk about the case a little bit. I just had a few studies that gave us some of the data that allowed us to develop this treatment plan. The first is this from Clinical Infectious Diseases. So 38 pregnancies in Peru. And actually, I actually printed this one out and showed it to her and her mother. They actually got, they were more confident in what I was saying when I was able to show them that it was Peruvian data. Because they had this idea that people in Peru knew how to do this, and they weren't really sure I did. But this is multi-drug-resistant tuberculosis in Peru, and it was 38 cases. 61% were cured by various drug combinations, which I'll show you in a second. 13% did actually die. The pregnant women died. 13% defaulted. There were 5 miscarriages and 1 premature birth, but the authors say that that's really not different than the usual expected rates in Lima, Peru. So looking at, and how do I'm going to make my cursor here. So looking at the regimens that were used, there was a significant amount of fluoroquinolone use in constructing the treatment regimens. And you see here, this graph is the resistance. A lot of INH, rifampin, PZA resistance. So this gave them and me, some confidence that the vast majority of these regimens that they were describing in this paper did contain a fluoroquinolone.
And Dave, is there any reason, I think, was it mostly ciprofloxacin that they were getting in this study?
It was mostly Cipro, yeah.
Is there any reason to think that Cipro and levofloxacin, and for that matter moxifloxacin, would have different toxicities?
So I would say no, although there is one paper, the next one, that showed a signal towards the possibility of increased toxicity with moxifloxacin, but in everything, Cipro and Levo really are equivalent. And I think there are better Levaquin data, both for TB and for pregnancy, than there is Cipro at this point.
Okay.
This study is actually a little dated, from '98, but was really talking about fluoroquinolone use in pregnancy, all comers. So this was over 200 women. Now, they showed no increase in congenital abnormalities, no fetal problems at all. But one of the concerns about this study, and actually many of the studies of antibiotic use in pregnancy in general, is the duration of antibiotic exposure. So when you're, for instance, talking about, treating a woman for a UTI for a week versus the entire duration of the pregnancy, there could be some differences. There are, though, case reports that are a little bit reassuring, as much as you can get from a case report, on the use of quinolones to treat osteomyelitis for months and months during pregnancy. And that gave me a little bit more comfort. And this is the one that we were talking about. This is actually, at least 2014 data. This is first trimester exposure to fluoroquinolones, 949 women versus 3796 controls. No change in birth defects, spontaneous abortions, but there was a non-significant increase, and I'll show that to you in the next slide, in birth defects with moxifloxacin. It didn't come to the level of significance, but when you see the numbers, that's one of the things that we were a little concerned about. These are the two caveats, though, down here. The first I want to say is that only 17% of these women were treated for more than 7 days. So while this is a good study, if you want to say, look, it's fine to use fluoroquinolones, and depending on which birth defect you're worried about, once you get out of the first trimester, it probably doesn't matter anyway. I'm not 100% sure that we're justified using, treatments of 7 days to talk about treatments of 9 months. But in this study, and actually multiple others, there is an increased risk of, increased rate of voluntary termination of pregnancy. And the authors speculated that that's because there is this concern that these drugs might not be safe and women are actually advised to terminate. And when you look at this study, so you see there was a lot of ciprofloxacin use. And look at our gestational weeks. 2, 3, pointing with this, the wrong thing. 2, 3, 4. I mean, this was really a study of women who didn't know they were pregnant and had gotten some antibiotics. The second most common was ofloxacin, because this is not a United States-based study. And then just looking down here, the blue, I guess that's a blue color line, that's the moxifloxacin. And while the risk of major birth defects does not reach statistical significance, it's more than the others, and if you believe that everything is the same, that Levaquin is just as good as moxifloxacin, maybe you have better data to go with the levofloxacin. And I think, at this point, if we really do believe equivalence, it doesn't really matter much. So I would say in conclusion,